Good evening, everybody. So today the topic of webinar is PRP beyond the hype, what really matters in clinical practice. And myself, Dr. Osama Niaz, I am associate professor in KGMU, Lucknow. And as we know that PRP is very important in PMR practice nowadays. We have shifted from steroid injection to PRP, and the main selling points are it is safe, it is autologous, and it has potential for tissue healing. So, but still, many clinician or many literature says it is not that effective or there is a hype. So that is what we will discuss today. So we have our expert Dr. Siddharth Rai, additional professor, Sanjay Gandhi Institute of Medical Sciences, Lucknow, and he has a area of interest in musculoskeletal rehab, interventional pain management, and diagnostic USG and interventional pain procedures. And he has various national and international publications and authored many chapters in textbook also. So he will discuss about the evidence, technique, and practical pulse in the musculoskeletal medicine regarding the PRP. So now, Dr. Siddharth, please start.
Thank you, Osama. Chalo. Hello and good evening, everyone. I would like to thank the Academy of Pain Physiatrists for the opportunity to speak today on a topic that has probably generated more excitement, more debate, and more confusion than any other intervention in the regenerative medicine, that is platelet-rich plasma. So in the last 10 years or over a past decade, PRP has been promoted maybe like a miracle cure to even calling it as an expensive placebo. And despite thousands of publications, increasing clinical use, and growing patient demands, many fundamental questions still remain unanswered. So the question is, why do some patients get remarkable improvement, whereas others show no benefit or maybe little benefit? I'm sure all of you must be seeing these cases in the OPDs. And why do some studies report excellent outcomes, while others report neutral or maybe even negative results? And perhaps the most important question is, are we truly evaluating PRP, or are we just evaluating collection of very different biological products under the same name? So today I would like to move beyond this hype and focus on what really matters in this practice. And by the end of the talk, I expect that all of you will look PRP not just as a single injection, but like a precise biological therapy that demands the right patient, the right injection, the right technique, and the right rehabilitation strategy. I hope my voice is audible and the screen is visible.
Yes, it is visible to me.
Yes. Okay, great. So I don't have any disclosures or financial relationships or affiliations with this presentation. Before I begin, I would like to ask my audience, is PRP overhyped or underhyped or appropriately used, or you are unsure? So this is an open question to the house. I would like to know your opinions. Let's start with the moderator. Osama, what do you feel?
In PMR, I would say we do not hype it. We are using it with caution and in appropriate patient. But as you know that it is not only used in PMR, it is used in orthopedics, in sports medicine, in plastic surgery, in dermatology also. And so I would say in some places it is hyped, and it is somewhere it is cost effective, somewhere it is not, but that doesn't matter cost. But yes, I would say in as some places it is hyped.
Okay. Rambir, you want to add something?
Yes, sir. Yes, sir.
What is your take?
Yes, sir. In some cases, it is underhyped, and I think I agree with Osama that we in PMR practice we are appropriately using. We are not using it. Isn't that is have very less evidences. We are using in most of the chronic musculoskeletal conditions. I think we are using appropriately, and the ortho colleagues and they are said that this is the PRP is overhyped, but we see the result as we are doing is PRP injection in ultrasound guidance. So I think this is also play a role in the effectiveness of the PRP.
Okay, thank you, Rambir. Is there anybody who wants to share his or her view? Whether it is appropriately being used, or it is underhyped, or it is overhyped, or unsure? So I personally believe it is underhyped. I think it has got much more potential. We still need to explore a lot about PRP, its role, its clinical pathologies. How can we better the preparation and the uses of PRP? So I think we need to do more focus on PRP, and it is currently underhyped. We need to use it more often. This is what I feel. Now, there is a PRP paradox. So most debates about PRP begin with the wrong question. Does PRP work? This is not the right question. The more important question should be which PRP, for which patient, how it is delivered, and followed by what rehabilitation. So there are two patients, patient A and patient B. Both have got similar clinical profile. Patient A is again a 52 years old male with a knee pain or knee osteoarthritis with KL grade 2, and he was first started on a conservative management. It failed and he was given PRP, which was LR PRP, leukocyte poor, under ultrasound guidance, a single injection, followed by very important, that was structured rehabilitation program. And that gave very good results to this patient. On the other hand, there was this other patient who was on a similar profile, similar clinical profile, similar pathological status, and similar injection, but he was just simply advised home-based exercise program, and the outcome was not that great. So the problem is that PRP is often discussed as a single treatment, when in reality it is a dozens of different biological products, different proteins, delivered to different patients with different pathologies. So we need to compare at that level. Now, why are we still debating PRP in 2026? After 2000, there has been a tremendous increase in the number of clinical trials, number of publications, number of researchers in the field of PRP. And there have been different publications, different research papers with a contradictory view. So when we read a paper labeled PRP, we often assume that it represents a single intervention. In reality, PRP differs in almost every variable that is possible. For example, they include different patient profile, different pathological level of those patients, different PRP preparation systems, different platelet doses, different leukocyte concentration, different injection techniques, and different rehabilitation protocols. So in essence, we are often comparing biologically different products and calling them PRP. For example, say we do a study on and different kind of antibiotics, and without specifying the dose, the duration, or the organism, we do a study. So will that make a sense? That is not going to make a sense. We'll call it absurd. So similarly, when we do a research on PRP, we read a paper on PRP, we need to make sure that all these parameters, all those determinants are also at the same level. Only then those results make some meaning. The real question is not whether PRP works or not work. The more important question is, again, like I said, which PRP, like what is the type of PRP, for which kind of patient, at what dose, delivered how, and followed by what rehabilitation. So all these parameters should also be viable. Now, this is the part one of this is my presentation, understanding PRP beyond the platelet count. So what actually lies inside the PRP? We all know first we have the platelets, which acts as a biological reservoirs of the growth factors. Upon activation, these platelets, they release these molecules such as platelet-derived growth factors or transferrin growth factors or insulin-derived growth factors that influence the tissue repair, does some kind of angiogenesis, cell proliferation, and extracellular matrix synthesis. Secondly, we have cytokines. These are the signaling molecules that regulate the inflammation and orchestrate the inflammatory process and the healing response. And depending on the preparation, PRP can contain both pro-inflammatory as well as anti-inflammatory mediators. Third, we have the WBCs or the leukocytes, which are the most controversial component of the PRP. Now, leukocytes may contribute to the host defense. They may prevent infection at that site and also in immunomodulation, but they can also increase the inflammatory signaling. And this is why distinction between leukocyte-rich and leukocyte-poor PRP has become clinically very important and very relevant. Fourth, the plasma itself is biologically active. Plasma contains different kinds of proteins such as fibrinogen, fibronectin, numerous proteins that serve as a scaffold for tissue repair and cellular migration and proliferation. Finally, depending on the preparation technique, PRP may also contain various degrees of red blood cell contamination, which is actually undesirable. We don't want RBCs inside the platelet because they cause tissue irritation and they may promote inflammation and cause more pain. So what I want to say through this slide is that PRP is not a single entity. It is a complex biological cocktail whose composition varies considerably between the preparation systems and the patient. And this variability also explains why two injections labeled as PRP may behave very differently in clinical practice. Just like our first question that I asked, in our clinical routine practice, we find some patients responding very well to those injections, some don't. That is because sometimes we treat PRP as a single entity, as a single drug, which is not true. Now, PRP classification, there are certain classifications, we all know about them, the PAW classification, the DEPA classification, and the Mishra classification. Different classification system, we do not need to remember and memorize all these, but different classification system describe different aspects of PRP biology, but all highlight one key fact that not all PRP preparations are same. They all differ in the dose, in the efficiency, in the purity, the leukocyte count, the platelet concentration, and activation status. Now, just like I said, PRP is not a drug. That is the biggest mistake in PRP research, is treating PRP as a single therapy. So PRP is not like a brufen. You cannot treat it like a hyaluronic acid or like a standardized product. So there are two clinicians. They both claim to be giving injections of PRP, but the biological product being injected may be dramatically different. So this is a picture of 4 different kind of PRPs. They all look same, but inside the composition, they are all very different. So PRP-A has got leukocyte rich with high platelet dose. PRP-B has got leukocyte poor and also low platelet dose. PRP-C has got an activated PRP, and PRP-D I cannot see in the image. It's cutting off. That is okay. So would we compare all antibiotics as if they're one treatment? No, we don't. If these products are all biologically different, why do we expect them to produce identical clinical outcomes? So that is not true. Therefore, we should determine what PRP are we talking about. Now, part 2, what really matters. So whenever we are going to decide that for this patient, we want to give for PRP injection, be it osteoarthritis or be it a soft tissue injury or something, so we always have to find out the 5 determinants that actually determine our outcome. The one is the patient, what is the diagnosis, what is the disease stage, then the product, third is the dose, fourth is the delivery method, and fifth is a very important rehabilitation. We'll study all one by one. Determinant 1 is the selection of the patient. So right patient matters more than the right PRP. So this is very important. Whenever you have to make a decision, you find out that whether this patient is suitable for a PRP injection or not. Only then the outcome will be as per your expectation. So the best candidates are those who have got a mild to moderate level of pathology. For example, knee osteoarthritis scale grade 2 or grade 3. Then chronic tendinopathy such as tennis elbow, patellar tendinopathy, Achilles tendinopathy, gluteal tendinopathy, or maybe rotator cuff tendinopathy, plantar fasciopathy, and active patients seeking functional improvement are the best candidates. There are certain class of patients which I would say to proceed with caution. Those who have got advanced osteoarthritis, such as KL grade 3 to 4, those who have got some kind of obesity, diabetes, a longer duration of illness, and multiple previous failed treatment. Okay. And besides this, there are poor candidates as well. Those who have a very low likelihood of meaningful benefits, such as the end-stage osteoarthritis, those with severe joint deformities, massive irreparable tendon tears, active smokers, and those with unrealistic expectation. Those who feel कि भाई हमने एक injection लगवा लिया and हमारा सारा problem खत्म हो जाएगा without doing any kind of rehabilitation. So these are those categories of patient who is not going to follow the treatment and they have unrealistic expectations. So the very important point which I want you to remember is PRP cannot reverse end stage structural pathology. So those patients are not the first choice for going for PRP. And the best outcomes occur when biology still has the capacity to respond. So PRP is not a magic. It amplifies the healing potential that already exists in the body. It cannot create biology where biology is exhausted. So those patients do not go for PRP as a first line of treatment. एक मिनट, सॉरी मेरा वो चला गया ना.
No, it is visible.
It's okay then. Sorry. Okay. So the next determinant is the very important, that is the PRP dose. So dose matters more than the volume. मेरी स्लाइड में ना एक चीज ये आ जा रही है, इसको थोड़ा मुझे छोटा करना है। ये देख पा रहे हो जो मूव कर रहा है मेरा?
Yes, sir. It's clearly visible.
पूरी
नहीं मेरे
whole slide is visible.
नहीं, स्लाइड तो विजिबल है, जो पार्टिसिपेंट्स का नाम है वो पूरी स्क्रीन पे मेरे आ रहा है बार बार, मेरे को स्लाइड ही नहीं दिख रही है। इसको छोटा कैसे कर सकते हैं? हाइट हम ओके,
So, sir,
हो गया, थैंक यू, गॉट इट। So sorry for the interruption. So
Yeah,
dose
fine.
matters more than the volume. Now this slide highlights what I believe is one of the most underappreciated concepts in the PRP, that is the dose. So there is 2 PRP kits and there are 2 patients, दोनों को 5-5 ml का PRP इंजेक्शन दिया गया, and they are very happy कि हाँ भाई तुमको 5 ml लगा, and I also got the same amount of volume. However, PRP kit A, it gave a rise of 1.5 times to the baseline. The volume was 5 ml and total platelet count was much lower, resulting in poor response. Whereas PRP kit B, it gave us a platelet concentration that was 6 times the baseline, and the volume was all the same, but total platelet dose was quite high, giving a better results. So what truly matters is the dose of platelet that we are injecting. You understand, not the volume. So platelet dose is determined by 2 factors: what was the platelet concentration in the PRP and what was the volume injected. So platelet dose will be platelet concentration multiplied by the injection. This may explain why 2 different studies using apparently similar injection volumes can report very different outcomes. And as the field of regenerative medicine is evolving, there is increasing recognition that standardizing platelet dose is more important than standardizing the volume. So we should always ask not the volume, but what was the platelet concentration that was given in the PRP, and then what was the volume, so that we get to have an idea that how many platelets were actually injected. Now, there have been numerous studies. They actually propose the magical figure of 5 billion platelets or sometimes 10 billion platelets that has to be injected for osteoarthritis and other conditions as well, that give better result. I don't know how much it is achievable or feasible, but we should always aim to know the exact platelet dose that we are injecting in that patient. Now, the fourth determinant is the precision delivery. Even the ideal patient that is receiving the right PRP, the right type of PRP, the right dose may not respond well because the biological was not delivered to the target tissue. Unlike systemic medications, which are absorbed in the body and then they travel by blood to the target tissue, PRP acts locally, right? So its effectiveness depends on where it is being placed. And this is where imaging guidance becomes critically important. Particularly when we are going injections in areas such as tennis elbow, plantar fasciitis, rotator cuff tendinopathy, or gluteal tendinopathy, we need to go for ultrasound guided injections. When outcomes are poor, we often question the PRP and also the dose. However, an equally important question has to be asked is what was the method of giving the injection, whether it was guided injection or it was a blind injection. So the message is same, that PRP cannot heal the tissue where it never reaches. Okay. Determinant 5 is our favorite topic, that is rehabilitation. So PRP is not a replacement of rehabilitation. PRP, it creates a biological environment where it facilitates healing, but rehabilitation provides a mechanical stimulus that is required for adaptation and functional recovery. So when I kind of explain to my patient, I tell them PRP is like a seed. I'm implanting that seed in the soil. And rehabilitation and the exercises program which you have to do is like providing that seed the water, the sunlight, the oxygen that is going to nurture that seed. And many times there have been studies and there have been evidences that increasingly suggest that the best outcomes are achieved when PRP is integrated into a comprehensive rehabilitation program rather than just delivered as a standalone intervention. This is similar to the first example that I gave. The patient was given equal volume, equal dose of platelets, a PRP injection, but the patient A had got under comprehensive rehab program and he gave the better results. So because without PRP, PRP without rehabilitation is a incomplete treatment. Part 3 is our physiatrist perspective. So this is very important again. Are we treating tissue or treating pain? So traditionally, platelets or PRP has been presented as a regenerative therapy. The assumption is straightforward that platelets, they release growth factors and other cytokines and other inflammatory molecules that repair the tissue, and pain improves as a consequence. However, clinical observation in certain cases were different. What happened? Many patients report meaningful clinical improvement immediately or within weeks of the injection. That is not possible because the tissue repair and the tendon, fascia, or cartilage often takes time for the repairing. So this raises a very important question. Does PRP also has role on pain modulation and neuroinflammation? And the answer is surprisingly yes. Emerging evidences suggest that PRP may influence inflammatory mediators, nociceptive pathways, pain signals, cytokines, and neuroimmune interactions that help in decreasing pain, along with its role as a regenerative medicine. So for us physiatrists, this distinction is very important. And perhaps the goal is not simply to regenerate the tissue, but also to modify the biological environment that generates the pain. So it has got a dual role. Now, this is again a very important question for us physiatrists, when to go for steroid and when to go for PRP. And the answer depends on the therapeutic goal, what we want to achieve. We all know corticosteroids, they have an excellent anti-inflammatory action and agents and often provide rapid symptomatic relief. However, their benefit is usually short-term benefits, and gradually the pathology, the symptoms, they reappears and there are repeat injections considered and potential tissue degeneration. However, PRP follows a different trajectory. Improvement is usually slower in the initial period, but benefits may last longer. And this is particularly relevant in conditions such as tendinopathies, plantar fasciitis, or knee osteoarthritis, where different studies demonstrate a crossover kind of treatment where steroids, they perform initially better, but for a long run, PRP performs better. So steroid wins the sprint and PRP wins the marathon. Besides this, there is another thing that we should keep in mind, match the treatment to the patient goal. So for example, there's a patient that has an upcoming wedding and he needs immediate relief. In those patients, maybe we can go for steroid first and maybe go for PRP at a later time. So these are the indications when we have to make judgment according to the patient demand and the scenario, which is better. Now, not all meta-analyses agree with the PRP role. If you search the PRP literature today, you can easily find publications that support PRP, and there are publications that say PRP has got no role and is like a placebo. Especially this publication which I've shared, the RESTORE publication trial that was published in JAMA, is often cited as the evidence against PRP. And similarly, there are studies and trials in hip and knee osteoarthritis that have reported neutral findings. And at the same time, multiple reviews and meta-analysis conclude that PRP provides meaningful clinical benefit also. So the question is not whether evidence exists on which side or which side is more. The real question is why these studies are giving different conclusions. So the answer again depends on the heterogeneity of the study population, which I said, all those determinants, were they equal or not? So what was the patient category? What was the age of the patient? What was the severity? What was the pathology of the disease? And what were the comorbidities which were there? What kind of product was injected, whether it was leukocyte rich, whether it was leukocyte poor, what the kit was used, what were the different methods of preparation, what was the dose that was given in the injections, was the delivery under blind injection or under ultrasound guidance, and what was the ideal rehabilitation procedure or protocol that was followed for in post-injection. This gives us the main thing that why the results are different. And should the negative trials affect us? Should we get disappointed because there are numerous negative trials in the world? But that is not true. So whenever we see a negative trial, we should not automatically interpret as a evidence against PRP. Instead, it should be viewed as an opportunity to understand which components of the treatment pathway may have contributed to that outcome. Delivery and improve the future outcome. Now, the last part is the part 4, second last part, practical clinical pearls for all of us who are using regularly PRP in our clinical practice. Whenever we prepare our PRP, we should also prepare a PRP report card. Every PRP should have a report card. We should know what is the platelet count, what is the platelet concentration, what is the recovery rate, what was the leukocyte content in that PRP, and degree of RBC contamination. Without these information, comparing outcomes between patients is not fine and not valid and becomes difficult. And also, if we do not characterize the product, we cannot truly evaluate the treatment. So we need to know whenever we are preparing a PRP, we are going to inject a patient, we should know all these factors routinely. There are certain common reasons for pitfalls. First is the very common, the wrong diagnosis. We took a patient who was at the last stage of the disease, who had got different joint deformities, and that gave to not that good result. Besides the wrong PRP, we need to match the PRP morphology, the PRP preparation type to the pathology, and also try to do most of the things in the under ultrasound guided and with the proper rehabilitation program. So if we monitor all these 5 determinants, we'll get the better results. There are certain complications and pitfalls which we see routinely. Sometimes we see post-injection flare, which is not that uncommon. There's increased pain, swelling, stiffness within the first 24 to 72 hours. And it is usually self-limited. We just simply need to reassure and monitor. Symptomatic treatment, we need to go for RICE, NSAIDs, and rest. Second, sometimes we can see infection, and asepsis is something that is non-negotiable, and we need to make sure that strict asepsis is being followed throughout the procedure. Sometimes there are failed expectations. PRP, we need to explain to that patient that PRP is not a guaranteed cure, and the results depends on the diagnosis, the disease stage, and the biology, and how much the patient's compliance is towards the rehabilitation. And last but not the least, we need to follow the medico-legal issues properly. We need to document well, we need to take the consent well, and communicate clearly to the patient. Last part is part 5. What are the future directions? So precision regenerative medicine is the future direction of the PRP. Rather than asking whether PRP works, we will be increasingly asking which PRP works for which type of patient. So the first step is matching the phenotype-based PRP, matching the right biological to the right pathology. For example, if we have an inflammatory phenotype, there is a lot of synovial effusion, inflammation, then we have to go for leukocyte poor kind of PRP. If there's a degenerative phenotype, there's an elderly patient who is presenting with the knee pain, with the osteoarthritis, then also we have to go for leukocyte poor PRP. However, the conditions such as tendinopathy, traumas, ligaments, muscle tears, we can go for leukocyte-rich kind of PRP. The second is the use of biomarkers to understand the pathology better and to predict better which patient is going to improve with the PRP response. And third is the artificial intelligence section, which may help integrating the clinical, the imaging, and the biological data to personalize the treatment options. Ultimately, the future is not about PRP, it is about the smarter PRP delivered to the right patient at the right time with the right strategy. Besides, as we look ahead, it is clear that there are 3 future trends that are going to dominate the regenerative medicine world in the future. And these 3 exciting areas are attracting significant research interest: targeted growth factor injections, exosomes therapies, and combination biological drugs. So we'll study in brief about these injections. The growth factor injections, the concept is straightforward. Instead of injecting the entire PRP, the entire platelet, we isolate and deliver specific growth factors, say platelet-derived growth factor or transforming growth factor or whatever, that are responsible for the tissue repair. And this offers the possibility of more targeted treatment for that thing, standardized therapy. However, the challenge is that the tissue healing depends on multiple interacting signaling molecules and not just a single growth factors. And unfortunately, today, at the moment, this is not FDA approved for routine musculoskeletal care. However, we have promising preclinical data and we have limited human clinical trials, and more RCTs are actually required. The second area is exosome therapy. Exosomes are tiny vesicles inside the cell, particularly the mesenchymal stromal cells. Now, rather than becoming the new cell themselves, these biological messengers, they pass on the message to the target tissue by delivering proteins, lipids, and microRNA, and they assist in inflammation, angiogenesis, and tissue regeneration. Just like growth factors, unfortunately, this is still not FDA approved and investigational only under the investigations for the clinical use. And standardization, dosing, and long-term safety are the issues that still need to be addressed. The third trend is combination biological therapy. Instead of relying on a single biological research product, people are trying to explore combination drugs such as PRP with hyaluronic acid or PRP with exosomes or PRP with other regenerative product. And the rationale is biological synergy, targeting multiple healing pathways simultaneously. Early studies have suggested potential benefits, but the evidence remains heterogeneous and larger trials still are needed. Now, only PRP with hyaluronic acid is partially FDA approved. Others are still under consideration and under research. So the key message is this, that PRP remains the biological, which has the strongest clinical evidence today, and growth factors, exosomes, and combination therapies represent exciting future trends, but they are still evolving and should currently be viewed as investigational rather than standard clinical care. So we'll conclude with our take-home messages. So I would like you to remember that PRP is a product and not a procedure. It is not like a drug. It is not a single product, but it is a cocktail of different molecules. Patient selection matters more than enthusiasm. Dose matters. That is very important. Ultrasound guidance matters. Rehabilitation matters. And success lies in matching the right biological product to the right patient. PRP is not one treatment. It is a treatment strategy that demands precision. Thank you.
Thank you, Dr. Siddharth, for this very precise and very well explained presentation. And
Thank you,
now I would like to ask the audience: is there any question from the audience? Please come forward and ask.
I would like to ask my audience, how many of you are actually using PRP in your routine clinical practice?
One question from Siddharth was, there's one question from Sarika, I think. Can we combine GFC and hyaluronic acid?
So just like I said, theoretically, it is possible because the mechanism is same. We are bombarding with a different biological product in the same tissue. But as per regulatory bodies, this is not approved. So if you want to go for research, you can go for ethical clearance and try to do more research under this. But ethically, it is not approved.
Yeah, I think also you should not mix, as in saving also, they say don't mix two things together. So here also, I would say don't mix two things together.
But PRP with hyaluronic acid is partially FDA approved, just like I said. So even those products are also available in the market. They are partially approved and you can use those instead.
I would like to ask, as you said, PRP is not standalone treatment and it is not the only treatment. So how many injections we should give maximum, matlab, average or maximum?
I assume that we are talking about the same pathological condition. So our patient population is
tendinopathies.
Tendinopathies. Most of the research, they recommend targeting the dose of the platelet and not the number of injection. So if we are able to achieve a high platelet dose, then single injection is also sufficient. In case we are not able to achieve that, then there are different trials, there are different opinions. Some say we can repeat the injection after a period of 2 to 3 weeks or 3 to 4 weeks, up to 3 injections. But that again depends. The main answer is what is the dose of platelet that we are aiming to achieve.
There's a question from Pragit. There any guidelines you follow for a PRP in a happy patient and an unhappy patient, especially in your clinical practice? Asking about duration, how long you can wait for a fail?
So this is a very important question, and this basically is dealing with the counseling of the patient. Whenever I go for a PRP injection in a patient, let us talk a very basic for osteoarthritis. I need to explain to that patient that what is my expectation from the injection and what is her or his expectation. If the patient says that I expect that after injection I'm going to run like anything and I'll be like a 16-year-old boy or a girl, that is not going to be met. So we need to explain that what is our aim of achieving in that disease pathology and what is her role also in the treatment, like the rehabilitation, that is very important. Weight reduction is very important. Following exercises, following knee care program, all those are important. And in total, that is going to lead to some kind of improvement. So this will be tackling ideally by the proper communication with that patient.
I think
the repeat dose already, Osama, you have asked, after how many days of PRP injection can we start rehabilitation? So ideally what is followed is just after injection, we advise for a rest for maybe 24 to 48 hours. We can also recommend ice fermentation locally and avoid any strenuous activity. Thereafter, gradually we start the rehabilitation program. And it also depends on the patient's tolerance. Some patients are too sensitive. They have pain after maybe for 4 or 5 days or maybe for a week. So as soon the patient is pain-free, the pain has decreased, we can start the rehabilitation program.
So I think they are asking few more.
Can we go for a prolo after PRP? That means after 4 weeks and then PRP. That doesn't make logically, sound, because those are again two different entities. We cannot compare both of them. They have different mechanism of action. They have different composition. So it will be difficult to compare both of them in the same patient. We won't be able to know. We understand that the benefit or the loss, who was contributing to that.
Dr. Siddharth?
Yeah, good evening, sir.
Good evening. Yeah. Like it's very well presented. Like I really like your presentation. So I
Thank you, sir.
would like to congratulate you. My question to you is, in one of the slides you said that PRP kit A and 1 or 2. One was, said like it was good result. Another kit you said that there was no good result.
Yes,
So
sir.
what really you mean by that? Like that means there are so many kits are available in the market. So did you compare amongst those kind of kit or something else like you would like to make?
No. Thank you, sir, for asking. I didn't mean comparing any different kind of kits available. I was just trying to show that the dose of the platelet is important rather than the volume of the platelets. So everybody we discussed, हमने 5 ml लगाया, हमने 7 ml लगाया, हमने 10 ml लगाया. That is not important. The most important thing that is to be kept in mind is that what is the dose of platelet that we are injecting. Suppose we are following or we are prescribing some market-based product or market-based kit, then also we always have to check that what platelet concentration are we achieving, what is the recovery rate, and what is the platelet dose that we are giving.
But how we are quantifying that which is the platelet rich, like so we are not quantifying, once we
are not quantifying.
plan to inject.
Yes, sir.
Ideally, it should be done, like prior to take the sample also.
Yes,
and after the preparation as well, right?
Absolutely.
Then only we could say like that there's a good platelet amount and which is really giving the good result, right?
Yeah, right, sir. That is what I mean to say.
Okay. Thank you. Thank you very much.
Thank you, sir.
That's very well presented.
Thank you, Rami.
So you told that the volume is not that much, then dose is possible. So in different conditions, we give only, in every condition we give the volume is should be kept 5 ml or 1 to ml is sufficient.
Rami, audio was not clear. Just repeat once again.
Like you said, the volume like 5 ml in knee joint, and in other conditions, like we are giving, want to give in other, like tendinopathy. So always volume is we kept 5 ml or 1 to 2 ml is sufficient.
Okay, how much volume you mean is sufficient?
Yes. Is there any minimum or maximum volume? You know that
again, just like I said, volume doesn't matter. You can give 2 ml also, you can give 3 ml also, you can go 10 ml also. What really matters is what is the platelet concentration that you're achieving. So when you are injecting regularly to those patients, you have an idea that what my kit or what my procedure usually gives us the rise. So if we are getting a rise of 5 times to 6 times, then you can simply calculate from the baseline dose. If assuming that we are getting 100% recovery from the platelet, that is not possible. But just to keep things simple, we can calculate that from this baseline platelet count, what will be the exact dosing which will be getting from that volume of the PRP. And by that calculation also, you can calculate that how much volume should be extracted from the tube.
So how much volume blood we should extract to make this tube 6 times?
Okay. So I'm assuming that my PRP is giving me a rise of 4 to 5 times, which I usually check regularly. Maybe every 2 to 3 patient I go for this thing investigation. Kitna rise mil raha hai. You check the baseline count of the patient. What was the platelet count of that patient? And exactly how much blood should have that much of platelet that you want to inject. So suppose I want to inject 5 billion platelets. They can simply calculate that 40 ml of blood or 60 ml of blood should have that platelet count. Then you centrifuge that blood and extract whatever the platelet concentrated baselines you are getting. And you can simply calculate by that way.
I have read that in some articles it is saying that 20 ml or 10 ml blood is not enough. You have to at least extract 60
Definitely
ml
not
blood.
enough. Nothing. Anything that is below 30 ml is all sham. Doesn't work.
So any kit you recommend to the audience?
No,
That is
I don't recommend any kit.
more than 30 ml capacity.
I want everybody to build from in-house without going for any commercially available kit, because even preparing with the normal centrifuge and tubes is also equally good.
So you took to make 30 ml, you took 3 tubes.
Depend what is the volume of that tube, no?
Okay, so these 30 ml tubes are available in the market.
Not in my hospital. What we get in our hospital is a 10 ml tube. So we have to calculate sometimes 3 or 4 ml 3 tubes we use.
So you use 3 tubes, 10 ml, 3 tubes.
Depend again, just like I said, na, we see the baseline platelet of the patient, and then we calculate what should be the volume of blood drawn from that patient.
One more question. Dr. Sarana is asking, can we use PRP in inflammatory conditions? Any evidence?
Yes, absolutely. But just like I said, in inflammatory condition, we need to go for leukocyte poor PRP. So right at the Buffy coat layer, we have to discard that the bottommost layer and take the amount that is above that Buffy coat.
He is specifically asking about rheumatoid arthritis.
I would say that if you inject PRP in a condition where there is effusion, it won't work. It
No.
will dilute.
I agree with Osama. Whenever you see an effusion in a patient, be it inflammatory or be it degenerative also, you always have to extract that effusion from the joint first and then go for the platelet-rich plasma. Without effusion, everything is going to be diluted and it is not going to work. So make sure that you aspirate the excess fluid, the synovial effusion which is there, and then go for injection. Somebody is asking, does this volume thing apply same to GFC as well? So I'm not sure how what is the platelet concentration, because they don't work on the platelet concentration. They claim that they have lysed that platelet and the growth factors have already released into the serum. I myself do not agree with that thing. I'm not very sure how much growth factors are stable at the room temperature or outside the body. We need to do studies over this properly, and we need to document that what exactly are we achieving, what is the concentration that is required for a particular growth factors, and what we are achieving in the tube or in the kit. Only then we'll be able to comment something. It still needs studies and trial.
I agree. But this bio-GFC thing is actually market-driven thing, basically.
Right.
It's not really a textbook thing.
So I don't agree with the concept of GFC much at the moment.
I have recently given 6 to 7 patients, and I have having good result in one injection. Almost tendinopathy and like ligament strain, chronic ligament strain.
I hope you are collecting the data.
Just I have on trial basis. I have started.
Actually, Rambir, no, this
Yes.
PRP, this PRP, it is evolving. We are using in different conditions. I will tell you new things, like we have used in early AVN, we have used in Perthes disease in the joint, hip joint, and we got many patients said they have pain relief, have substantial pain relief. So, but I cannot say that, okay, AVN is reversed or this Perthes disease is cured, but the pain was released.
Yes.
So that thing, I think Dr. Siddharth explained the pain.
Yes. That it has also got role in pain modulation.
Yeah, that. So I think if there is no more questions, so we should conclude the session.
The word of PRP and PFC and exosomes.
Sir, Siddharth, any closing remarks? Take home message for the audience.
That was my closing remark, that I want all of you to go for extensive studies and more research in this field. It is still underexplored, and just like I feel it is underhyped, and it needs more trials and more robust studies to prove how can we make it better and how can we make better use of these biologicals.
Thank you, sir. Thank you so much.